So now we have none other than Professor Dr. KHOKHAR, and I think he's one of the most experienced ICL surgeons in India, and he'll enrich us with his vast experience from cornea to lens, the safety and efficacy of ICL. All to you, sir.
Yep. Thank you, Son. Thanks to the STAR team to have me on board. I promised them that I should come at the end so that I see what people have already presented, so it becomes easy for me to step onto them and climb up. Okay, so when we started surgeries a few years back, it was only cornea, and we're doing the PRKs, and PRKs, and by the way, they're coming back, PRKs coming back. Then we started having LASIK, E-LASIK, C-LASIK, D-LASIK, whatever. Then you got smiles. But the thing was that you're taking the tissue away from the cornea, and which eye can you predict will go into ectasia? Anybody can predict that? Nobody. People can have PRK with ectasia. You can have any corneal surgery, we can land up into ectasia. So that element of doubt is always there. So why can't you go for something which is as good as a phakic lens in which you're adding? So you're not taking away, you're adding. So when you add, people always they want more, I know. If you get more interest, of course, you'll put more money into that one. So you want more. So I think the same holds true here also. Okay, so what I'm going to talk about is, okay, that's a disclosure. See, to start with, there's no risk which is too low for a refractive surgery patients. These are individuals with the glasses, they are 20/20 or 6x6 vision, leading their life absolutely fine till they get some peer pressure or they're applying for some job in which they need to get rid of glasses. Which again, I don't think is a good thing to remove the glasses for the job, because you can again have a refractive error later and can land up in more trouble. So till then, they are absolutely normal individual living their life. I still see about 60% of people wearing their glasses. I don't know why they didn't get their cornea cut off. So refractive error is actually going on the rise, and the myopia is on the rise. If you see that 36% of the distant disability is because of refractive error, and by 2050, it's anticipated that 5 billion of the population is going to be having refractive error, and 10 billion will be high myopes. When I say high myopes, I mean it might be out of the range of the corneal refractive surgery. So this is why this symposia becomes very important. Everybody has to learn how to do ICLs. And a normal average cataract surgeon can actually go and pick it up without any problems. Okay, so here we go. So spectacles you can give contact lenses in the refractive surgery. See, in the 19th century, world wanted wisdom, and they became wise, right? They were reading a lot of literature. Everybody was onto all these big literary guys in 19th century. Then came 20th century. We had the little left angle. People wanted to fight, wanted freedom, and they got freedom. Most of the places, when they broke into smaller pieces, it was happening in 20th century. And now the 21st century wants the world to see the world without glasses. See, all these patients which used to come to me 20 years back, 30 years back for refractive, and which they come now. Now these kids are so aggressive, they want to get surgery immediately. When they come, they say, just operate. Earlier, we used to evaluate, talk back, go back to the family, come back if you're ready or not. And we were also skeptical because the machine was not up to the mark and the lenses are not good. Like people talk about PR lenses falling into the vitreous. But now I think we have reached a place where it's very safe. Even my kid, if I have to do, I'll do it for him. Earlier, we used to think twice, actually, right? Even the doctors. In fact, I put ICLs in the last 15 days in about 5 to 6 doctors who had come for their own ICLs in the eye. I mean, they're surgeons, they are anesthesia guys, and they're happy about it. So they want independence from glasses. So we know all the modalities available to us, and this is, if you see the protocol here, according to FDA, this is the only surgery ICL which covers the broadest range from spherical plus and minus both with the high cylinder. So as I say, all the refractive procedure being a corneal or otherwise, it has to be a stable myopia. And cornea, there's a problem. You have to have a residual bed thickness, and if the cornea is too steep or too flat, again, you can't go for the corneal procedure. And ectasia is always a problem, and you can have incomplete flaps, you can have vertical gas breakthrough. There's so many complications which can happen in the cornea which are not at all there in the phakic lenses. So what if the patient does not fall in the criteria? If the patient is a hyperope patient and patient has myopia more than 8 or high cylinder? So these were the rejects from the corneal surgery which was coming for ICLs, but that's not true anymore. In my clinic, even a 1.5 diopter minus is offered a ICL, and you'll be surprised how many of them are actually picking up, okay, for this surgery. So implantable is the same thing. The criteria are all the same. Lens power has to be stable, If it's varying, there's no point to put in the implants because you'll have to go touch up later on. The only thing which has come is you have to look at the anterior chamber depth, and we do a gonioscopy in all the patients, manual gonioscopy, and we have the anterior, and we use the anterior also, and we can actually find the angle, which Sanjay showed at 30 degrees, we can pick up in all images, and you can follow these patients up, and that way your 2.6 might be 2. You can make 6 into 8 easily, but 2.5, it's a little skeptical there. Endothelial count is important because especially for the beginners, if you're not very good at it and you might cause an issue there, you're viscoelastic, the pressure goes up. If your specular count is good, you can go ahead and do all these patients without any problems. So there are lots of phakic lenses, but there are only 2 which are FDA approved. One is the ICL, and another was the Verices, which nobody is using now. So there are lots of players which have come with the different materials. Those materials might be good as an IOL. When you do a cataract surgery and put an implant in the back, that's fair enough. But when it comes to a lens which has to respect the anterior capsule as well as the corneal endothelium, I think there's no material which is better than Colemar, and we've been using for the last 30 years. And incidentally, when we operated few patients now for the cataract, we realized when you took these lenses out, there was not even a speck of any dust on that. There's nothing, no addition of anything, and they were absolutely clear. So the sizing, as everybody said, is good. What I say is you do a refraction yourself in all these patients. If you have an error in the refractive error, so garbage in will be garbage out. If you put a wrong refractive error, your result is never going to change. Okay, so your refraction is very important. Sizing, I think everybody's talked about. I'm going to just skip the sizing. This is a article in which Pope et al., which they published. They measured about ICL sizing from angle to angle, circle to circle. It's an old article. The only flaw was they used a 50 megahertz probe for the UBM. And they have to take 3 pictures and make a collage. So it already had an error in that. So I don't believe in that. These are the 4 sizes available. So you have to make sure that the patient fits into this one. Whenever I have to err on the size, I always err on a little larger size. I want a little higher vault than a little lower vault. So why 4 sizes? Because if you see this study, in this study, there were thousands of patients taken from the normal age from, say, 20 till 50, 60 years, male, female, and they found out the result that majority of the patients actually are fitting into the criteria. About 90 plus patients are fitting into this criteria, so that's why the lenses are there. Even if you change the size of the lenses to say 11.25, 11.75, still variation will be there because it's not going to fit. It's not like buying a ready-made shirt versus the one which you get tailored made. So there's going to be always a variation, but because of the material and the such soft haptics, this problem of about 1 millimeter can easily be compensated in this one because these haptics are actually malleable and they can adjust in the periphery very well. Okay, so people have discussed all the sizing. I'm going to skip the video surgery. I think everybody's a good surgeon. So why should I use a phakic lens on a corneal surgery? Because phakic lens can be performed for any routine person. You don't need to have a femto machine in which you can't do a fumigation. You have to switch over. Your routine cataract setup is good enough for you. You take caliper, you measure anterior chamber depth. You can go ahead and get your surgery started the next day. You don't have to worry for all these things. Like even the surface problems are there, you don't have any problems in that one. It's a reversible thing. There are lots of patients who get this surgery. We had a patient in which did a LASIK, and somehow after the surgery, his vision was 6.5. But somehow he got into his head that this is not good for me. He wants it to be replaced, reversed. You can't do that because the tissue is already lost, right? Here, if you have situation, you can always go ahead and take it out. Visual recovery, all these studies say that even if the smile, as last thing you talk about, this has the best vision, which is in 6 months post-op, they might be similar, but in the first 6 months, it's like that. The safety index, there's no doubt about that, this is the best. Even an average cataract surgeon can actually go and do this. For smile and all those, you have to be a lamellar surgeon. You should know where the planes are. There's a little learning curve there that's not here. So these all studies just say the quality vision, of course, is par excellence. It negates all the ectasia association. There's no study in the literature which say that you've done an ICL and you got an ectasia. Okay? Even in the patient in which you have a stable keratoconus, you've done a C3R, and for last 2 years it has not progressed. We put ICLs and we followed them up. There was no change because you're not actually screwing up with the cornea per se. When you cut the cornea, it reacts. The metalloproteinases, you don't know how you're going to behave with that. So any of these, it's apoptosis. So anything can trigger on the cornea. So that's why you have to be very careful about the corneal surgery. Saying that, we got 2 suits. We do lots of those ones. But still, if the patient wants refractive, we always go for the phakic lenses. So phakic lenses, pre-op, okay now. When these patients go old and you want to do a cataract surgery on this one, we are getting the patient which we've done now 20, 25 years back, and these myopes will have cataract little earlier, nuclear sclerosis. So I do the biometry the day I want to operate, and whatever my value is, I go ahead and do it, because the column is such thin that it does not cause a change in the deviation or the velocity of the sound which is going through. So we published a paper, this was 10 years back, in which we did a preoperative measurement of the exit length. We followed this patient for 3, 4, 5 years, and we realized it doesn't make a difference, actually. Okay? So keratometry doesn't change because the incision at 2.2. Whatever's happened at the surgery, by the time the cataract comes about 15, 20 years back, it's already stabilized. Your keratometry, your exit length, whatever you get the day of the surgery is the true value for you. You don't have to go for a D1 value, preoperative, cornea, refractive, what was the surgery done earlier. Nobody keeps the data these days. So this is a safest method. Now, the other paper we published was on the stereo acuity outcome. How many people have managed patients, say, minus 16, minus 18? Can I see a raise of hands? Okay, so 1, 2, 3. So on these patients, you can't do a corneal surgery, because if you take the cornea will be ectasia only. So we did a study in all these 15 plus ones, and we realized all these patients who could never had a stereo acuity now started having a gross stereo acuity and the depth perception. So that means they can go and watch the Avatar movie without any problem, which they can't do because the corneal surgery is not going to help them. So this is another thing which can add. Especially these patients are stereo blind because of minus 16, minus 7, minus 18. But after the ICL, because of the maximization factor, they could appreciate the depth also. Okay, this example, I think I can skip because I think Ramurthy is here and the time is also up. So it's not that it's a reject of refractive corneal surgery that you have to take up. You can take up patient otherwise also, and you can offer them. And I'm telling you, all the patients are going to be happy. Just the last slide. The new modifications come, I think, which is talked about. So I choose ICL in a practice, but it's safe, it's predictable. There's no loss of contrast at all. You do a PRK, anything, because once you have an interface, you're going to have a contrast loss. No regression in these one, and this is reversible. The red zone is the cost factor, which I think the star people should reduce the cost, which they have to discuss. Sizing is a limitation, but you have to work on the sizing. And it's an intraocular surgery. But now the kids are so aggressive, they don't mind actually intraocular surgery. So they're happier in the visual outcome. The next day is 20/20. We operate both the eyes on the same day. I use 2 hours. I do one patient. And after 2 hours, I do the other eye in the other OR with the other machine after washing. So it's like 2 different OTs for the same patient on the same day. And with that, I'll close. Thank you very much.
Thank you, Dr. KHOKHAR, sir, for that wonderful talk. Any quick question to Dr. Sudarshan KHOKHAR, sir?
Sure, please.
Yeah. Can we have the mic, please? Can we have the mic?
I think it's loud enough.
Yeah.
Okay. Right, so if I have a patient which was 618 pre-op BCVA and I put an ICL in this patient, the vision actually comes 6.9 later on. And the reason is that you have got magnification. If you see the magnification factor, when you see the logmar, when you jump from one light to another, it's 1 logmar, which is 1.3396582571. So every time you change it, 25% magnification happens when you add the nodal point, which happens only with ICLs. So even the amblyoptic eyes, the vision improves. And we realized that 618 patients are 6.9, and with pinhole, they come into 6 partial. Then we went and checked the literature. They said if you have the magnification, if the magnification is given 25%, you get 1 line. So in the ET PRS chart, each line has a 1 logmar jump. So we can get 2 lines or 3 lines depending on the patient. But if it's a grossly organic lesions on the macula, it's not going to change. We do lots of myopics which are 636, but they have lesions in the retina on the macula. So we do it because they don't wear the big glasses. But amblyoptic patients do get some vision back. Arun? Oh, yeah, these were gross stereo acuities, but still close to 150, between 100 to 3. So we had about a 7 to 8 patient in this group. It's not a big study, but it's there. On the other hand, if you've done in a eyes in which there's not a high power, I think it crosses, it's like a high definition TV they're watching, I think.
Thank you, sir.
Is that good? Thank you. Sorry? But then, if the eye is small, the lens will not go in. I think, can you make smaller lenses for sir? I mean, so the problem is the sizing. So all these ones with the abnormalities in the eye, small eye, colobomas, this is not meant for those people, actually. Right, sir? Sir is a pediatric ophthalmologist, so that's why he's talking about the micron. It doesn't work there, sir. No. Sorry.